Very good morning to all of you. I would like to invite our chairperson, Dr. Tariq Qureshi sir, and co-chairperson, Dr. Omkar Telang, and the moderator for the session would be Dr. Srinivas Joshi. So, Friends Thinking Under the Apple Tree is a special session of the ARC, which involves inculcating the young researchers the research-oriented skills in our ophthalmologists, and that is why this is a very special session. Can we have the moderator slides on, please? Please put the moderator slides on.
Judges, evaluation.
Our respected judges will be given evaluation sheets, and all the contestants will be evaluated according to the rules that have been put forward. So can we have this first slide? Yeah. This is our moderator for the session, Dr. Srinivas Joshi. He has been the ARC South for the second term, and he's been a brilliant academician and a brilliant VR surgeon and a very dedicated ARC member of the South. Next slide, please. Yeah, our chairperson, Professor Dr. Tariq Qureshi sir. He is the principal of the Government Medical College, Anantnag, and a very brilliant and vitreoretinal surgeon and laser specialist. He has bagged several awards, and we are really very fortunate to have him as our chairperson. Next slide. Dr. Omkar Telang is the professor and head of department of the KJ Somaiya Medical College, Mumbai. And he is an excellent teacher and very fond teacher, and we are very happy and blessed to have him as our co-chairperson. Next, please. Our judges can...
Yeah, we have Professor Brigadier Dr. Shyam Sundar sir, the gold medalist from Pune University, and he's in the United Force Commanders Certificate Appreciation in 2010. So we would like to welcome one of our most distinguished judges today, Professor Shyam Sundar sir, to the Think Under the Apple Tree, please. Next slide, please. And we have Dr. Radhika Natarajan, Deputy Director, Cornea and Refractive Surgery at the prestigious Shankar Nethralaya, Chennai. She has around 26 years of clinical, academic and research mentoring experience. Welcome, ma'am. Dr. Radhika, madam. And then we have ever-smiling Dr. Vineet Ratra, the Senior Consultant at Shankar Nethralaya, Chennai. He has bagged many awards. You can see the list of achievements and the professional achievements. And definitely, he has also served as an international faculty at CMER Shenzhen Eye Hospital from 2014 to 15. Welcome, Dr. Ratra, sir. We have Dr. Somen Mishra, the Professor and Head of Ophthalmology at AIMS Raipur. And he has bagged the AIOS International Award in the year 2019. Welcome, Dr. Somen, sir. So the rules, as you are all aware, it's a 4 minutes presentation. Discussion time after the presentation will be 2 minutes. So the judges already have the score sheet here with them. So it will be based on the novelty, the practical application, what's the clinical impact your study is going to give, and what's the cost efficacy of that study, or what are the product if you are displaying it, and what's the potential commercial viability of that product in case if you are trying to patent it. So the total marks will be 100, and top 10 again will have to present in the final round at 3:30 p.m. in the same hall, level 2.
Just one more thing. At 3 minutes there will be a beep, and at 4 minutes the screen will be blank. So request all of you to please stick to time so that you will get complete marks for that.
Okay. All the best. Yeah. So do we have the first presenter, Dr. Swapnil Kothari?
No, he's not coming. It's written.
He's not coming.
Yeah.
Dr. Neeraj Israni. So please welcome Dr. Neeraj Israni, the first presenter of AIOS 2024 at Kolkata.
Request the next speaker to keep the slides ready on the other podium.
Dr. Arvind is not there. We can have Prasanna Venkatesh Ramesh. Can we have some pens, please, for the judges? Pen leke aaye.
Any doubts regarding?
Mic is not working. Yeah, very good morning. Honored to be the first presenter of AIOS 2024. So mine is a video presentation, and the topic is head-mounted handheld slit lamp, a novel innovation. I'll start the video.
Has to screen hundreds of patients.
Yeah.
Dr. George has to screen hundreds of patients for cataracts, media opacities, and corneal infections in CAM settings. His trusted optometrists are often unable to give him objective clinical information with just a torchlight. High quality slit lamps are expensive or not portable. Dr. George then thought, what if we could make our own head-mounted slit lamp, taking inspiration from our very own indirect ophthalmoscope, which includes a headband, optics, and illumination. Thus, we created a blueprint and came up with this very own head-mounted handheld slit lamp. The head-mounted slit lamp has various components. The main component is a simple, lightweight head mount with adjustable strap. It has adjustable LED lights for diffuse illumination. Also, we can incorporate magnification attachments of different diopters in the fixed slot provided as seen over here. This is made up of the same material used in mobile screen magnifying devices. The head mount is lightweight and can be worn for long hours without any pressure. The handheld slit lamp, on the other hand, has a filter slot as seen over here. It also incorporates a 4-watt LED torch as seen here. We provide 2 filters of different slit sizes. One of the filters also has a cobalt blue fitting. On simple sliding of the filter, one can project a slit beam of light or a diffuse beam of light or the blue cobalt filter as seen over here. The other filter has a size of the slit which is even thinner. The final step is to use both these together. As seen here, the handheld slit can be held in the right hand of the surgeon for the left eye of the patient, and the slit size can be easily adjusted with the help of the filter. The head-mounted device, on the other hand, plays a role to magnify the image of the eye. It not only provides a good magnification, but can also be used to identify many diseases of the eye. Our head-mounted handheld slit lamp can be used for bedridden patients, pediatric age group, and also in CAM setups. On comparing our device with handheld mobile-based slit lamps, the pros are that it is economical, easy to use, and lightweight. The only con is that recording is not available with our device, and it is purely a screening device.
Thank you. So the entire cost of the device is not more than 3,000 rupees, and I have the, I couldn't unfortunately get the head device, but I have the handheld slit lamp with me, which, as I've explained, it gives diffuse illumination, and just with a slide of this, it gives us a slit. And the idea over here is that there are various devices in the market, but none of them give us slit handheld devices, and it is very cost effective. I've been using it in a lot of CAM patients and a lot of pediatric age group as well as bedridden ICU patients. Works wonders for me.
Neeraj, it's a very nice concept.
Thank
I
you.
have a couple of quick questions for you. Being a cornea specialist myself, I understand it's a screening device, but in a real slit lamp, the table-mounted one, the angle between the observation and the illumination plays a crucial role in the formation of the parallelepiped and what you view.
Correct.
So here, that is very subjective because your hand is the one which is making the slit and the illumination is coming from above, number one.
Correct.
And number two, if you're anyway going to use the handheld piece for your slit adjustment, then why reinvent the wheel? You can simply have that cylinder in your hand and you can use the indirect ophthalmoscope illumination itself in a modified manner. Why to,
I was expecting this question.
why to repeat that
So
invention?
the head mount, the IDO, that is the indirect ophthalmoscope, will not give you this kind of a magnification. If you've seen the video, there are different magnification glass pieces which I've put. So I have a small table which I have made over here. So you will not get that kind of magnification. Your focal length and the magnification varies a lot. So you will not end up seeing what you see. With the magnifying glasses that you put, you can put up to 2 or even 3 with the third one. Your focal length becomes as much as that you don't have to go very close to the patient. That is point number one. Secondly, you don't need to persistently put the illumination from that. The illumination also comes from this. And as long as your question, seeing the parallelepiped or the slit, so all you have to do is just, if this is the diffuse, all you have to do is just tilt it, and through the magnifying glass, you actually see a slit section. I mean, if you can also see the endothelium and the epithelium, what you see on a normal slit lamp. So this is basically what we've done is we've broken down the slit lamp. We've taken the same proprietary technique, put it into this parallelepiped cylinder, so that first of all it is cheaper and it makes it easier for us.
Just a question.
Sure.
Do you have a battery backup for this?
Sir, if I may just show you right now, this is a 4 watt torch. If I just open this for you, it's just a single battery. So this is a normal ever-ready single battery that I've put inside. As simple as that.
Okay. And magnification, what range are you looking at?
So we have actually put all magnifications here. So we have gone, there are different magnifications right from 3x to 5x to 8x also. You can combine, so there are 2 slots and there's one extra slot which basically comes from top, which gives us a 8x. So it can go up to 14x almost.
In that case, you need to go scale up to a revolving wheel or something. It's going to be extremely cumbersome to keep placing these glasses back in.
So yes, you have to, depending on what you are seeing, if you're just seeing a cataract, you have to use a normal magnification. If you know that it's a corneal condition, you will have to put that magnification prior hand, making it cost effective. Otherwise, a wheel would make it very more expensive.
Thank you.
Thank you so much.
Dr. Neeraj. And I request Radhika madam to please offer him the certificate. As not only as the participant under the apple tree, but also as the first presenter of AIOC 2024 Kolkata.
Yeah, I would like to invite the next presenter, a novel human in the loop AI toolbox for multimodal assessment of anterior chamber angles, Dr. Prasanna.
Yeah. Thank you for this opportunity to present on my innovation. So artificial intelligence, is it the hype or the real McCoy? So this is something that is real and happening, my dear friends. When we started to unlock the phone with our fingerprints, with our face, and then we have the first unmanned car which can even stop at places such as the speed breakers, the traffic, and then we had the first NASA plane which was unmanned and it can fly on its own. So slowly but surely it started coming into place, and we wanted to break the black box dilemma, why the AI is working the way it is working, and we invented a convolutional neural network with real confocal images using human intelligence. So that's the USP of our innovation. So we used a convolutional neural network just like the human CNS system, and the AI has to undergo a growth just like from a baby to an adult, and we used a medical image annotation tool where 2 human interfaces were there. The AI was not given full control. The humans annotated and taught the AI, and humans also validated it. If something was wrong, we took the responsibility and then changed it. You can see that each small findings were annotated, a cup, a disc, an RNFL defect. A single image was spent almost 15-20 minutes to annotate, and then the machine learning was taking place With more annotation, the precision, recall, the mean average precision all improved, and the diagnosis alone did not happen, but along with the diagnosis you also got the intricate findings. You can see in this particular scenario, when the image is fed, even the RNFL defect is obtained, as you can see in this box here. So these intricate findings along with the diagnosis helped us in an explainable AI, and we also evaluated it with sensitivity and specificity. We wanted to push ourselves more. We went into the angle. So this was the technique that we used. You can see the green dot, the trabecular meshwork, and the yellow one, the sclera. And then a perpendicular was drawn from the trabecular meshwork, and a novel protractor was innovated for the angles as well. So we used a multimodal UBM, Anterion, ASOCT, and Scheimpflug imaging. 4 angle devices were used, and Anterion showed more promising results in the training. And the train 3, you can see with each training the mission was actually improving. And you can see the sensitivity and specificity, 82, 88, and 95 in the subsequent ones. Even the specificity, you can see it is 92, 94, and 95. So with more training, the human training, you can see this is the image. So with train 1, you can see the actual angle is 24.76. It is 27 that the machine predicts. With the subsequent one, you can see the 24.76. It is 22. Only a 2 differences there. Then with subsequent training, the 24 now becomes a 23. So that's what human in the loop brings in along with the AI. And this is an app that has been launched where you just need to drag the angle image, be it a UBM or an Anterion. You just need to drag it and put it into the app that we have made. And you can see that the image automatically annotates because of the human learning. You can see the image is now loading, and it automatically comes into a annotation. Yeah, I'm just showing this video here. So now it is loading, and once the loading process is done, the image loads itself, and you can see the annotation is automatically done. So then we also went ahead with an OCT algorithm, not only to diagnose but also to grade, because in OCT we have the visual and the digital markers to grade the glaucoma. So all these 3 innovations are in the smartphone, and it is called human in the loop training, and we have developed an extensive baby. Under 60 seconds we get this. In fundus we diagnose along with the intricate findings. In angle AI we differentiate the glaucoma, quantify the angle, and for AIOC decision making, and for OCT AI we diagnose and grade the severity. So this is holistic glaucoma at the maximum, and we are pushing ourselves into MIGS as well, where the angle dynamics, this is a paper which is due for publication, which is very promising. So ultimately it's for the community, and this is my team along with a group of engineers, ophthalmologists, optometrists. This is a lifelong study that we have done, a 5-year study along with seniors like Dr. Murli Ariga sir, Satyan sir, with Sandstone collaboration, etc. Thank you once again for giving this opportunity.
So fantastic thought process here, Prasanna.
Yes, sir.
Do you think this is going to replace gonioscopy?
So gonioscopy cannot be replaced because gonioscopy is the visualization test that we tend to do. But what our idea is, in the rural community or in vision centers or in telemedicine when it is on the rise now, with a single modality such as a fundus or a OCT, we cannot go forward. Artificial intelligence has to be multimodal. A disease like glaucoma has to be approached as much as holistic as possible, because fundus gives only certain findings. With OCT we get certain more. So now how can we add more into it? Adding the CCT, adding the visual fields. Even in our calculator we have added the IOP as well. So this is almost a 5-year work that we have shared, sir. So the more data that we can add on to it, the more the sensitivity and specificity will be there. But definitely human touch examinations will always be human touch examinations, but we can definitely diagnose better, because just with a smartphone, you take a photograph and you put it into the app, you get as much as possible data as possible, so that referrals, telemedicine, primary health centers, they all can benefit. Even when we do a screening with a smartphone, all this really matters at the end of the day, sir.
So it's more a helpful tool rather than a replacement for normal.
Yes, sir. My emphasis is on AI. It should be an helpful tool, because that is why we created 2 human interfaces called human in the loop training. Never give AI the total power, because at the end of the day it is the human who make the decisions. But when we have 2 human interfaces, one for teaching and one for predicting, the human interfaces will always help correcting and modulating the machine much better. Just like for takeoff and landing, the pilot holds the flight rather than giving the total control to the AI. Yes, sir.
Thank you.
Nice, Dr. Prasanna. How many patients have you tested this on?
Sir, for fundus we have used up to 8,000 images. For the multimodal angle images, we have used 1400 images for each of the angles, because taking into consideration I may have an anterion, another person may have an ASOCT or a Scheimpflug or a UBM, and for OCT images again we have brought in 4 centers. Each centers have given mild, moderate and severe. Each have given around 200 to 300 images for each category. So it's a multi-centric trial, and we have done it, completed around 3 to 4 years of follow-up, sir.
What would
Yeah.
You have used all these images to train the AI, but
Yes.
then the output, how are you calibrating it?
So
Like
the-
all false we've done some trials for infection
Yes, ma'am.
hepatitis using AI and deep learning. What we found out was you need to go ahead and see these images are fed to train the AI. Once you build the AI, the output also has to be validated. Otherwise, false positives, false negatives can become a problem. So how do you do that calibration?
Yes, ma'am. So the results that was evaluated was the outputs, ma'am. So we had images used for training, and for testing we didn't use the same images that we used for training. We used a different cohort of images for testing. So the training images and the testing images were not the same, and the testing images data was the sensitivity and specificity that I presented. So the images were divided into 2. The training images were not used for testing. Yeah.
cost issues?
So the application, as you can see, the AIOCT, it is still not launched, but the fundus and the angle, it is already launched free of cost, sir. For the benefit of the rural public, we are aiming the rural community in the developing world, so it is already launched. We didn't have a charge or anything, sir. Yeah. Yeah.
So you are giving it free of cost for all the people who have watched here at the first instance?
Sir,
Thank
the
you,
idea.
thank you, Prasanna Ramesh.
Thank you,
Venkat.
sir.
Thank you so much.
Thank you, sir.
I now request Dr. Omkar Telang sir to please honor the certificate to Prasanna Venkatesh Ramesh, please. Very good, very good. But that will not be counted for the marks. Thank you so much. Now we have Dr. Ashwini Kumar will be presenting on visual rehabilitation with household artifacts and living space modification.
Thank you very much, All India Science Society, and my behalf Science Society, namely Dr. Satyajit Sinha sir, who not only saved my life, but showed me the way to start a new life ahead. Dr. Satyajit, I'll be really indebted to you for life. I had a brain hemorrhage, sir, so I'm paralyzed. So Satyajit Sinha sir showed me a new way. He saved my life, sir. The whole society saved me. Now I'm starting a presentation. I was a surgeon before, but now I can't operate. So it's a new thing I'm starting. Thank you so much. So I conducted an experimental study in 55 low vision 8 patients in Patna. At that time, the patients were not aware of low vision, so the patients were very less. I took the consent from all the patients. No invasive techniques was used, as majority of the patients were from poor socio-economic background. Common household items were used to help the patient with low manners to manage their daily activities. On follow-up, majority of the patients expressed satisfaction and ability to perform simple day-to-day tasks. The researcher recommended usage of these items in low resource households. So there was a bell-shaped distribution of patients who participated in the research in majority of subjects in 2nd to 5th decade of life. Only 1/5 of the subjects were female and 4/5 were male. Subjects came from the variety of occupational backgrounds. Most of the patients attending the clinic are poor, as Mahavir Netralaya, where I'm posted, is run by a charitable trust. 25% of the patients were retired, 13% were students, and 44% were housemakers. So the visual acuity of subjects were overwhelmingly poor and had limited scope of correction using the lenses of glasses. Well over half visual acuity poorer than 6/16 both eyes. They all complained of inability to perform daily tasks and unable to benefit from surgery, medication, or use of any spectacles. So the subjects all report difficulty performing common household tasks. However, it was surprising that a majority complained about inability to view mobile and watch television as the causes of highest concern. The other prominent causes of concern were writing and moving outside the homes. A variety of household items and were easily developed at home to help them. depending on their needs. Over 30% reported that the cardboard tool for counting the currency was the most useful. It's called Notex. Among others, improved household techniques were management, arrangement of use of torchlight more often, cardboard tool of writing, and kitchen training, which I'm doing going home from home, how to cook with less light, because they can't cook with holding magnifying in one hand. So I teach them how to change the color of the objects and all, color of the room and all. Yes, sir. Then some people it was very useful also when I told them to use the special utensils. The patient satisfaction was rated among a scale of 1 for 5 to among being least and 5 most successful. A majority of the patients reported a high satisfaction with a 95% rating, a satisfaction rate of 9 and above. Thank you so much. And I feel the low vision aid is a worth trying thing, sir. Satish Sinha sir will agree. Because Bihar is our Mahavendra is a poor state, poor patients are very poor. So I started a new techniques where घर की चीजें से आप कर सकते हैं, needle threader, torch light. How I go to kitchen with my driver because I can't walk. So I tell them how to cook with less light, to change the wall colors, to use special utensil and all. Thank you very much. Thank you. Thank you very much.
Very nice initiative. Thank you, Dr. Ashwini.
Thank you, Ashwini Kumar sir, for that wonderful presentation. I request Omkar Telang sir to please honor him with the certificate of participation.
दिख रहे हैं? थैंक यू. इसको पकड़ लीजिए, हम तो नीचे उतरते हैं. हाँ सर, इसको ले ले सर. हाँ सर, सतीश सर ने तो आराम ही चलेंगे सर. तो ही इज लाइक फादर फिगर फॉर मी सर.
Okay, thank you. So we can have the next presenter, Dr. Arvind Kumar Maurya. Because of another presentation, another hall, so he had to be there. So he'll be presenting on the OmniFlow. Over to Dr. Maurya, please.
Thank you. Greetings. I am presenting a new innovation, OmniFlow, a novel, small and effective drainage device for complicated open-angle glaucomas. Routine trabeculectomy with or without implants are associated with many complications like shallow anterior chamber, choroidal detachment, phlebitis, long surgical time, etc. OmniFlow is a sutureless, short shunt to drain aqueous from anterior chamber to the retrobulbar space behind the equator, which is virtually free from fibrosis even without mitomycin C and can drain up to 500 microliter per minute. This is how this 50 millimeter length with 0.3 into 0.7 millimeter drainage device looks. It works on the principle of Bernoulli's and Hagen-Poiseuille, means an increase in speed of fluid with a decrease in pressure or fluid's potential energy even against gravity twists and turns. After putting a L-shaped cut in the conjunctiva and after little blunt dissection, vectis insertion to reach retrobulbar space. Up to 40 millimeter of wire vectis can be inserted with ease and it creates a track. After this, at 45 degrees and 5 to 7 millimeter away from the limbus, a scleral tunnel is made with 23 gauge angled MVR plate. This tunnel is properly lubricated with 2% HPMC. The beveled end of OmniFlow is now inserted and passed through the scleral tunnel. 3/4 length of the OmniFlow tube is pulled out and the walled distal end of the tube is inserted into the retrobulbar space, which goes into the retrobulbar space quite smoothly. Now, a second scleral tunnel is made, which is radial or perpendicular to the limbus up to 2 to 2.5 millimeter from behind the limbus, which is then gently entered into the anterior chamber, bisecting the angle of anterior chamber and the iris. Now, the beveled end of the OmniFlow tube is inserted into the anterior chamber via this tunnel. Care must be taken that only the beveled 1.5 to 2 millimeter end goes inside. Conjunctival flap can be glued or sutured. This is a case of double OmniFlow. IOP was around 100 millimeter of Hg in a one-eyed patient who had undergone multiple RD surgeries with repeated silicone oil injections with multiple failed trabeculectomy. After surgery, IOP came down to 19. These were the results in the clinical study with success rate of over 95% in 29 eyes. IOP came down from 30 to 70 millimeter of Hg to 10 to 15 millimeter of Hg immediately after the surgery. 24 patients maintained this level of IOP without any medications till a year. 4 patients required 1 anti-glaucoma medication. There was no loss of vision and lines in any patient. So, in conclusion, OmniFlow will revolutionize the management of all types of primary or secondary intractable open-angle glaucoma, neovascular rubeotic glaucoma, silicone oil-induced angle recession, posterior embryotoxin, and glaucoma in Sturge-Weber syndrome by keeping IOP between 10 and teens 24/7 and free from complications of trabeculectomy. My acknowledgements. Thank you.
Thank you.
Yeah, good thought, Dr. Maurya. So just a few questions. One is, most of these newer ones come with the, whichever the ones which we use come with a plate. Even the RD or the Ahmed valve come with a plate, though they are more anterior. The reason was that less scarring and more spread. In yours, there is no valve.
Yeah,
so
there is
how
no
many,
valve, sir.
How many shallowings of the anterior
None, sir.
chamber?
None, sir.
Corneal touch,
No, sir.
Hypotony.
None. Because we are using it in
Hypotony.
open-angle glaucoma. No hypotony. No.
extrusions.
No, sir. Not till now. We have done 173 cases at 3 centers and there is no complication. It's a very small, I think I can show it to you. It's very small.
How many times did the tube get blocked?
It haven't blocked, sir. Not a single case
hasn't.
till now. No. There is a Teflon valve if you see at the end.
Okay.
So it opens up and it closes up depending on the how much the anterior chamber has the pressure. If the pressure is very high, so there will be it will open up fully, 175 to 225 microns, right? And if the IOP is lesser, so there will be only trickling of the aqueous, right, sir? And if the IOP is between teen and teens, we have adjusted the Teflon valve, so then it will there won't be any drainage. So this is the advantage that it doesn't require that bulky, like the Ahmed valve plate, nothing, just into the retrobulbar space, and retrobulbar space is free of myofibroblasts.
But it would still fibrose.
No, we haven't observed any. There are 3 studies in glaucoma, so they have then I put the reference also in my this, so that it is free of myofibroblasts.
Oh.
That's why we are able to exploit that space. And the aqueous drainage is only 2.8 microliter per minute, but this tube can drain up to 500 microliter per minute, up to 170 times higher.
how long has the follow-up been, Dr. Arvind?
It's 3 years now, sir. It's 3 years now. And it's commercially available also now, 7.5 thousand.
7,500.
Yeah.
What is the need to have that L shape? Why should there be a kink in the tube? There is a horizontal passage and then there is a vertical passage into
To
that
able
L
to
shape.
keep it fixed, ma'am. And the Bernoulli's principle, I said as this movie, na? So this kinetic energy, the potential energy of fluid, even without gravity, twist and turn, they will have some kinetic force. So we are utilizing.
That turn I'm asking you, instead of having one horizontal and one vertical scleral support,
Yeah.
you can have two vertical scleral supports. So that
Yeah,
need to
the surgeons are using different technology.
bulbar space. There's no need to have that L-shaped kink is what I'm trying to ask.
Yeah.
Because you have a purpose for it.
Yeah. Means to fixate it, and so many surgeons, they are using different technique. But it's not kinking, it's just a turn. So it doesn't hamper any fluid or the aqueous. Never.
Thank you so much. Now I request Ratra sir to please present Dr. Maurya a certificate. Thank you, Dr. Maurya, for that presentation.
Actually, it doesn't need so much. You can put a straight tube also.
I request our past ARC member, Dr. Satyajit Sinha, to please co-moderate with me. So next we have Dr. Santosh Agarwal is already there, and an innovative, simple and novel AC paracentesis device.
So, respected judges and chairman's desk, very good morning to all. I am going to present a video on and also some text on intravitreal injection, my innovative technique. It is more of a technique than a device. So as you know, intravitreal injection widely used to administer anti-VEGF, triamcinolone, antibiotics, TPA, etc. What are the risk factors involved in intravitreal injection is vitreous incarceration in the wound, vitreous weak through scleral tunnel, a bleb formation at the end of the injection, immediate increase in IOP which can endanger the optic nerve perfusion, and transient CRA occlusion. Increased risk of endophthalmitis because vitreous can adhere to the needle wound, and RD can happen because of the vitreous traction that can cause RD. So this is my simple and novel AC paracentesis device wherein 26 or 30 gauge needle is used and its hub is mounted on a sterile Johnson bud. It remains inside antechamber throughout the injection to drain out aqueous as the intraocular volume increases because of your intravitreal injection. The chances of iris and lens touch can be avoided by piercing the needle at limbus tangentially into antechamber. Just the bevel is partially, just the tip of that bevel is inside the antechamber. So even if it moves, it will not damage intraocular structures. So the advantage is no immediate hypotony because you are have a guarded outflow or egress, and there is no AC collapse as against direct bare needle entry. While giving intravitreal injection, aqueous drained out slowly in a guarded fashion, soaked into the tip of the bud. Avoid immediate rise in IOP and its potential complications. Mostly useful when triamcinolone or multiple injections are given in endophthalmitis. No vitreous or drag reflux at the site of injection. No vitreous weak, its potential complications. Less chances of endophthalmitis and RD. So I have done the studies also. I won't go in detail. Just this is the small video. This is my pre-injection paracentesis needle. I have just pierced in the antechamber. The tip is just inside. It is not touching the corneal endothelium or the iris. And I have already given the injection. The volume is taken care of by that AC paracentesis device. So how I make it, just to show it, it's just Johnson bud I have pierced into the hub of this needle. You can use 30 gauge needle also. This is a very simple, inexpensive device. No money is required. And this is the intravitreal injection. This I am piercing this just inside. Even if it in phakic eye, it will not harm, it will not move. Even if it moves, nothing will happen. For last 5 years, I am using this technique, and it is very rewarding, no pain to the patient. And this Again, the same technique. This patient's response, I think sound, please volume. Audio visual. Audio.
इंजेक्शन दिया है
हाँ
तो इंजेक्शन के मेरे को चीटी काटती इतना भी दर्द नहीं हुआ,
बिल्कुल भी दर्द नहीं हुआ
मालूम भी नहीं पड़ा इंजेक्शन दिया कि नहीं दिया।
So this is a very good advantage that the patient don't feel any pain because there is no increase in the volume of intraocular pressure.
ओके, तो अभी आपको ठीक लग रहा है, कोई तकलीफ नहीं है, कुछ भी
तकलीफ नहीं मेरे को।
चलेगा। ओके, थैंक।
So it's the patient's feedback. So we have done the studies, and I will go to directly to the discussion. Bleb formation is very less, 0.8% as against 20% in other studies. CRA occlusion 1.61% as against 30%. Vitreous incarceration, RD, and endophthalmitis all were very, very less in our studies. And pain during procedure was null. So dramatic effect of this new technique on intraoperative and postoperative were observed. There is hardly any bleb formation, vitreous incarceration, or any other related potential complication observed, and there is no pain. So to conclude, this is a simple, inexpensive AC paracentesis device which is found very useful in all types of intravitreal injections, especially in triamcinolone and multiple injections in endophthalmitis. Thank you very much for your patient listening.
A fantastic idea. I think very practical and very fantastic to, especially for those who have raised, and generally when they give intravitreal, they say you should have a reflux, so that takes care vitreous doesn't come out.
Yeah.
Good thought process.
Thank you, sir. Thank you so much.
Dr. Agarwal, I have a quick question for you. It may decide the price also. Are you the same Santosh who was doing fellowship when I was back in Shankar Netralaya as a postgraduate?
Yeah. Thank you.
Dr. Santosh sir, out of the judges' question, so do you do this AC paracentesis in all the cases of intravitreal injections, or only in cases where you have the risk of glaucoma or the patient is already a glaucomatous patient?
Yeah, in those cases that is mandatory, I think.
No,
And
I'm
also
asking
in
whether
multiple injection in endophthalmitis, and also in triamcinolone because it's a high volume. Mostly in triamcinolone and endophthalmitis.
You don't use it in routine intravitreal anti-VEGF injection because
I
you had
use it.
written anti-VEGF.
Myself I use it, but many people they are very afraid of that injection is touching the lens or the iris. But I don't find any problem.
Okay. Thank you, sir. Thank you.
Thank you very much.
Thank you very much. I request Brigadier sir to please honor Dr. Santosh Agarwal with the certificate, please.
Fundamed eye drops, eye drop prescriber, reminder tracker and monitor by Dr. John Akra.
Yes, sir. So I am Dr. John Davis Akra, and my innovation is an app. I call it Fundamed eye drops or Fundamed QRX because it uses QR codes. So ophthalmologists diagnose several diseases and treat them by prescribing eye drops. We think that is the end of it, but that is not the end of it. The important step is the patient should use the eye drops correctly and follow the schedule correctly. That is often ignored. Many patients, they use the drops incorrectly or misusing them, and especially these tapering schedules of post-op medications, uveitis treatment, and also long-term glaucoma treatment whenever we change the medications, that is very confusing for them. In the long term, such critical diseases such as glaucoma, every missed drop leads to permanently lost nerve fibers. So that is permanent. So even if patients find and install a medication reminder app, they find it very cumbersome to feed in the doctor's prescription into their phone. So there are two big roadblocks there: getting a good app, using it, and feeding in the prescription also. So the feeding in the data should be ideally done by medical personnel for accurate entry. And our approach is to solve all these problems at once by using QRX technology. So that is QR code and RX prescription. So what we do is we create an easy to use app for doctors to prescribe eye drops with error prevention also built in. so that if you cannot give a wrong dosage, it will give an error message. And also to transmit that prescription to the patient's phone using a QR code. Why QR code? Because it is quick and fast. Then when the patient scans this QR code, it opens or installs the app for them and then loads this prescribed QR code medication prescription into their phone. And this app can provide reminders and track the medication adherence on a daily basis. And later they can share it with the doctor at the next visit in case of privacy concerns. Or if they want to, we can maybe in future have a direct sending of the data to the doctors. Patients can also update their symptoms. So if they have some side effect to some particular medicine, they can immediately update on the app. I am having redness and irritation when I put this drop at this time, so that they don't forget it. It comes on the timeline of the doctor's information. And also any other symptoms, any other side effects can be noted. So this will help in foolproof medication for all these diseases such as uveitis, post-surgery, glaucoma, corneal ulcer, and all these, everything which needs proper medication. So app concept was designed, modified with a good interface was planned, and functions include prescribing for the doctor, receiving prescription for the patient, then reminding, tracking and monitoring by alarms on the patient side. And possible drug interactions and contraindications, systemic diseases, all those were also planned to be introduced into the logic of the app. And the existing medications, whatever is easily available, that database will be entered, but can be also updated by the patient or doctor. This is what the app looks like. So it will have this doctor-patient separate login page. So once you go into the doctor page, you will have to fill in the patient information and also the medication information. In addition, you can also do tapering medication. Then you click generate QR code, and then you get the QR code, and then you can show the patient their app. They open a QR scanner and load this QR code into their app, and they get the prescription on their phone. And that converts into alarms on the patient side. So that is basically what the app is supposed to be. So it's supposed to be an easy to use app for prescribing, receiving medication prescription, and tracking. So that is what I would like to present. Thank you.
Thank you. Can we have the question?
Innovative idea, but can you have this even on a computer, the app, or is it only on a smartphone?
So it's basically a web app, so you can have it on a computer as well. It will be HTML based, so it will run on a browser. Chrome, it will run on Chrome.
Okay. Because what I would tell my patients now is to set an alarm on the clock, on their phone.
Okay.
So that every time that you have to have a
So you can make sure that they set the alarm correctly. Because if you have an EMR, I have not yet integrated this into an EMR. So if the EMR company allows, I would like this to be part of the EMR prescription setup. So once the prescription is done, generate QRX. So QR code treatment, it will just generate a QR code. Patient will just scan from the EMR screen itself. Can be a laptop, can be a tab, can be a desktop. And immediately the correct prescription goes into their phone. You don't have to worry whether they set the alarms wrongly. And also it will show the medication, which one is supposed to be administered. So it is much better than an alarm. And also the tapering doses can also be set. Alarm cannot do tapering doses.
Is there a way that you could put a photograph of the drop?
Yes, sir. Yes, sir. That's what. So on the alarm, it would show the photograph of the eye drop. So that we have to customize that. You have to take a photograph of the bottle and put it. Right now, the database has to be put separately for all these medications. So pictures have to be added separately. So the alarm will show which bottle they have to use.
And what is the cost of your app?
So I want to make it absolutely free. Cost of developing, there is a small amount, but if we keep it paid, nobody will use it. I want it to be free.
Very, very good idea.
Thank you, sir.
Thank you. I'd like to request sir to please give a certificate to Dr. John. Next, we would like to invite Dr. Ankit Agarwal, who will be speaking on an innovative low-cost dry eye treatment. Dr. Ankit.
Thank you, sir. I would like to thank AIOS for the wonderful opportunity to present my innovation. I have no financial interest in this. So dry eye is defined as a dysfunction of lacrimal functional unit, that is the integrated system comprising of lacrimal glands, ocular surface and lids, and sensory motor neurons that connect them. The most common dry eye, which is prevalent in India, it seems that it's a meibomian gland dysfunction, because India is slowly becoming the diabetes capital of the world, and meibomian gland dysfunction is highly associated with patients who have uncontrolled diabetes and poor lid hygiene. The treatment modalities available for dry eye range from topical lubricant drops like carboxymethyl cellulose to anti-inflammatory agents like cephalosporin and more. Various device-based therapies have come up in recent years, which basically act by increasing the meibomian gland secretion either by heating and expression, that is the LipiFlow-based techniques, or by reducing the inflammation of meibomian gland, that is the IPL-based techniques. But the problem with these devices are they are very costly. They're ranging from in the range of 25, 30 lakhs to rupees 40, 50 lakhs, depending on which company you buy them from. Keeping this in mind, we have designed an innovative approach to dry eye treatment, where a low-cost device is used, which gives a similar result to these. The purpose is to describe an innovative low-cost dry eye therapy system as compared to the much costlier alternatives which are available in the market. The study was performed at a tertiary eye care hospital in North India, and the therapy protocol was designed wherein a low-cost heater cum massager costing about rupees 10,000 only was used to treat dry eye diseases caused due to meibomian gland dysfunction. A data of 39 patients aged between 43 and 59 years was collected. Of these, 27 patients underwent therapy using the novel device, and 12 patients were referred to other centers to get therapy using the traditional method. 12 patients were referred to other centers to get therapy using the novel devices, and our own few patients were used traditional method. The eye massager unit for dry eye looks like this. So this is the patient in which dry eye therapy is being done. What it does is that it heats the area surrounding the eye and the lids to about 45 degrees Celsius, and it has certain massage points. That is, 9 massage points are there in and around lids, and vibration is also there. So it massages, it vibrates, and it heats, giving the patient a good feeling as well as giving meibomian gland chances to relieve. The device is used for 15 minutes at a time and once every 3 days for 15 days, that is total 6 sessions. At the end of 1 month and 3 months, the following data was checked, that is Shermer's test, TBUT, and OSGI questionnaire. All patients were prescribed 1% CMC eye drops, irrespective of which therapy was being done, and the results of these tests were compared with those from before treatment. The low-cost device reduced the incidence of MGD at 1 and 3 months as confirmed a normal post-treatment Shermer's test and TBUT. The traditional treatment group also had significant improvements in their Shermer's and TBUT values, especially after 3 months of therapy. The patients in both were also symptomatically much better from before therapy. So these are the test reports. That is the Shermer's test, the mean pre-value treatment in MGD patients was 24.8 mm at 5 minutes, while at 1 month with novel device it was 16.7, while with traditional therapy it was 19.1 mm, while at 3 months it came down to 14.2 and 14.7 in both the therapies, which is compared to normal values approximately. The TBUT also increased to a normal range around 10 seconds after 3 months in both the therapies. But the difference comes at 1 month, that is in the novel device at 1 month the patient symptoms have much improved. There wasn't much difference between the two groups at 3 months. So in conclusion, this innovative solution is a low-cost alternative to devices which are available and thus make the therapy cheaper for the patients as well as for doctors to afford. Thank you.
Thank you, Dr. Ankit. Questions, please.
So again, this is doable and low cost as it may seem. It seems to me to be a slightly glorified version of warm compresses that we normally prescribe to the patient, only that you're specifying the heat and the duration and the pressure points.
Yes, ma'am.
So again, 2 questions. Calibration, how often do we achieve what we set out to in terms of the temperature and everything? Question number 2, how do you explain the increase in the Shermer value because of this treatment?
the Schirmer value decreases, ma'am. Actually, in MGD, I have told them Schirmer value decreases with the treatment. The pre-treatment Schirmer values were around 25
You mean to say the
seconds.
reflex steering comes down?
Yes,
How do
reflex
you-
steering comes down because MGD is causing so much inflammation. The inflammation reduces, the reflex steering reduces. with
Okay. How about the device calibration in the sense that how do you know that this is the temperature that will work for mybomitis? Do you have any objective tests like mybography before and after to
We don't
base
have a
your
mammographer
claim?
machine, but we took photos using our AR. We took photos of the meibomian glands, and we found that the pre and post treatment, the patient meibomian gland improved. As well, what we relied mostly on is the OSGI questionnaire. The symptomatically patients were much better, and they were very happy with the device. And because it's so cheap, we were offering it for free. Basically, that okay, sit for half an hour in our OPD, and just we'll do that.
Yeah, that may
So-
work like that, but if you want to make it a little more objective, do you see whether there is what kind of meibomian insufficiency is there? Is it a blockage or a dropout before you actually advise this?
Ma'am, blockage. If it's the total dropout, then it's very difficult to do with this because it's a blockage based.
Thank you. I'd like to.
How expensive is this?
About 10,000 rupees, sir.
You can ask.
How is it different from what is available on Amazon? Because I've seen this, I'm
Yeah,
using this, it's same
that's what.
almost.
It's
4,000.
available on Amazon.
Yeah,
But the
that
problem
costs
with
around
those devices are that the temperature and how much amount of pressure, each product has different. So they will write that this is there, but when you measure it using a thermometer, you will find that it is different. So I collaborated with I collaborated with OEM manufacturer from China only. I gave them the specification that I want 15-minute continuous therapy. I want pressure at these points. So they made this device and they priced it at rupees 10,000 to me.
Okay, because I'm myself, I'm using this. I have
Yeah,
two devices, so because the pictures.
Amazon is generically. See, I bought from Amazon. Then I contacted that person there to get it made according to my specifications. So the pictures were sent by him. That's why you have seen those pictures before.
Yes, thank you.
Thank you. Can I request Dr. Radhika Natarajan ma'am to please give a certificate to Dr. Ankit Agarwal?
Request Dr. Devi Aishwarya to present her.
Good morning, everybody. So I'll be talking on Tenon's patch graft with amniotic membrane graft and overlay technique. Yeah, so we know there are different modalities of managing corneal perforations and thinnings. Out of them, Tenon's patch graft is a known modality. The traditional method of doing this was an inlay graft, wherein an excess amount of Tenon's tissue was dissected and placed as an inlay graft in the area of thinning or perforation, and then it was secured by large cross sutures and then sometimes covered with amniotic membrane and a BCL. What we see is the pre-op and the post-op of such a technique. So you can see there's quite a large amount of vascularization, of course less than cyanoacrylate glue. There were reported cases of anatomical failure and clinical failure. How does it work? When we combine the goodness of Tenon's and amniotic membrane, Tenon's, as we know, is a fibrous, thick, rich in muscle tissue and muscle fibers and fibroblasts. It produces autologous fibroblasts in connective tissue, and it gives structural support, reduces inflammation. Amniotic membrane, as we know, is rich in growth factors. It has antibacterial, anti-inflammatory, anti-fibrotic, anti-angiogenic effect. So now coming to the video. Yeah, so we infiltrate that area where we are going to dissect. I usually choose the inferior fornix. Then we dissect out just an adequate amount of Tenon's, not any excess amount of Tenon's, just enough to cover the area of thinning. And we place it as an overlay, not as an inlay. How I came upon this technique was by accident. I had an accidental perforation on table when I was giving intracameral, and I had not taken a consent for therapeutic grafting. And so in the absence of anything, I just resorted to using the patient's own tenons, and I put it as an overlay because I could not place it as an inlay. So now as you see, I'm simply securing that just adequate amount of tenons with 4 tenonylon sutures, just adequate to cover that area. And on this, now that we have a dry base, we can just put a sufficient amount of amniotic membrane on it with the help of fibrin glue. In the absence of fibrin glue, we can use the patient's own blood, but since we have access to fibrin glue, I use that. And then I cover this area with just adequate amount of amniotic membrane so that post-operatively I can have a view of what's happening beneath it. And then once this is done, I just excise the excess amount of amniotic membrane outside of that graft area and then cover it with the BCL. And then follow up the patients as I would do any corneal ulcer patient. And then I put glue and I secure that area of conjunctival opening. So that's the end of the video. At the end, I put a BCL. So now these are some of my pre-op and post-op cases. As you can see, this is the first post-op day. In the traditional technique, because of the excess amount of tenons that we are using, excessive amount of post-operative swelling was causing loss of tenons adherence over there. And you can see how well the graft has taken up. It has integrated into the corneal tissue. Now this is another large desmetocele, more than 5 millimeter. Here you can see the post-op results after 2 weeks. This is one more. This is after 3 months post-op. This is one case which was almost lost. She was willing to give up the eye, an old lady. And in this case with the fistula, I had very little choice. I either had to subject her to a tectonic graft, which she was unwilling. So in the absence of everything, and since she was willing to give her eye up, I just put a tenons patch graft, and you can see how well she did after 3 months. So this is how well it has integrated. So now I had 18 cases with a minimum of 3 months post-op, and all of them had good anatomical success. 10 had more than 2 lines improvement, 6 underwent cataract surgery and had more than 4 lines improvement on the Snellen's chart. 2 remained less than 660, and they would subsequently need an OPK, but they were OPK ready. So in the absence of, so what I hope this helps us take a different look at the way we do therapeutic grafts and tectonic grafts. And it's absolutely low cost. It is more universal. It can be done on any patient. And it does not need a HOTA registration. Most of the corneal surgeons still remain without access to HOTA in our country. So I think it will help us save a lot more eyes. Thank you.
Aishwarya, yeah. So I have a lot of things to ask you. Good presentation. I think it was the rescue measure that you tried out and then you got caught on with it and then you took it further. I would first of all take severe objection to your saying that it is a low cost measure. Anything that involves amniotic membrane usage in the surgery can never be low cost, because
and as compared to a
I have not yet finished asking what I want to ask. So procuring the membrane, to cleaning the membrane, to preserving the membrane, to using the membrane itself increases the inherent cost of the procedure. But my actual question was, the way I understood the first case which led on to your usage of this technique later, did have a perforation where there was an iris prolapse which was sealing the perforation temporarily. So what did you do about the iris prolapse if you had to just put tenons as an overlay?
Wherever the iris is at the wound already, ma'am, after I cover it with tenons, and
so you did not attempt to deepithelize or replace the iris prolapse. You have just placed the tenons on top.
After the wound is secured, ma'am, then I replace it through a
paracentesis.
Side port.
Paracentesis.
Yeah.
So in that case, it wouldn't have been possible to deepithelize the iris, right? So in an iris prolapse, when we do the tenons as a graft, normally you deepithelize the iris, that immediately opens up the perforation, and then you put the tenons as an inlay and then cover it up with a bandage contact lens. Here you cannot clean up the iris because you are putting the tenons as an overlay. It is not an inlay. So the moment you don't clean up the iris and you put it back, you pave way for future epithelial downgrowth and problems like that. I wouldn't be in favor of doing that.
Can I speak, ma'am? In perforations where there is iris already at the wound, I remove all the debris on the iris. Then I remove the de-epithelize the surrounding area till I get to the healthy area. Then I put enough tenons to cover that area of iris prolapse as well as a little bit of the healthy cornea, and then fill it up and then top it up with amniotic membrane. Once that is done, then I go in and I try to separate the iris.
Okay, even in that case, I would feel, it's my personal view, that usage of Tenon's patch and amniotic membrane together is an overkill. You could try this technique of overlay if you've cleaned up the iris and then you've put the membrane and then you have reposited the iris from a side port is what you're trying to tell me. You could still do that and do away with the amniotic membrane and just try a bandage contact lens on top. If it works in this, it should work in that also. I understand and agree that you are providing, trophic factors, but with the use of the amniotic membrane. But then it considerably increases the complexity of the procedure as well as the cost. If you really want to try it, I think you should also have an alternative where you use only a bandage contact lens and see whether it works equally well.
Because I was using sutures to secure the graft and sometimes the peripheral. That is why I was covering up with amniotic membrane so that inside's less vascularization. That was my thought
A
process.
BCL will cover it equally well. And regarding your problem of graft loss, there is a simple tip that you can follow. When you're harvesting the tenons, you made a point that you take the exact amount. There is no need to take an exact amount. Tenons is a free and easily available tissue. So long as you don't leave that opening exposed, you can take as much tenons as you want. So what I do is you take a little larger piece of graft, and then I put cautery marks in it. The cautery marks help to shrink the tenons. So once you do that, the ballooning up of the tenons because of aqueous outflow, the amount of vascularization that invites, much later after the procedure, these seem to come down once the spaces are shrunk in the tenons tissue. Small tip, you can take it if you want.
That's just what I was trying to emphasize, that in the absence of access to HOTA, and this is more doable for most of us. Like, the cost effectivity as compared to a corneal graft is less.
Definitely, but I wouldn't use both together unless I figure out one works alone as well.
Thank you.
Thank you. I'd like to request Dr. Vineet Ratra sir to please give a certificate of appreciation to Dr. Devi. So that brings us to the end of this session. I would like to thank all the judges over here. And can I request Dr. Jyotirmay Biswas sir to please give a certificate of appreciation to all the judges, please, sir. Can I request Dr. Brigadier K. Shyam Sundar sir to please come. Dr. Radhika Natarajan ma'am. Idhar sir. Dr. Vineet Ratra. Sorry. Can we request all the presenters to please come up for a group picture, please? Yes, definitely. I'd like